Episode 73, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format through expert analysis. Today's expert is Dr. Kheriaty. He has written extensively and has had many public debates on physician-assisted suicide. As you might be aware, in 1997, the state of Oregon legalized physician-assisted suicide and has ushered in a bit of a wave in the United States, as a number of other states, most recently California, just a few years ago. I think you'll find the discussion on physician-assisted suicide to be interesting on a few levels. For one thing, you don't have to be a specialist as a physician to follow the conversation, because although there's some technical knowledge in how to kill someone, certainly it's not things specific to medical training. Also, it's more of an ethical and political discussion in what the proper role is of the law, of physicians, and of patients and family members in the act of suicide. We go into how suicide is actually a social phenomenon, one that tends to aggregate. I know there are a lot of moral panics that are begun with the concern about copycat crimes and things like that, but I think it's certainly with suicide, it's well documented that there is a social effect, and the acceptance of it changes the rate of suicide. And most of us, I would presume, feel very concerned if someone in our family were to commit suicide. I know we oftentimes look at the physician-assisted suicide in the lens of someone who is on their deathbed, or they're, for whatever reason, they're just unable to commit the final act. But most people who are given the pills that are for death are actually able-bodied in the sense that they probably could find other means of committing suicide. And so we'll get into exactly what the implications are of having physicians involved and what the society's legal system, how that changes the perceptions from those in the society, and what it changes as far as end-of-life discussions that physicians might have that are totally unrelated to suicide, but these are discussions we have all the time in the ICUs and the hospitals around the country. There are a number of pieces that Dr. Kheriaty has written. Those will be linked at the show notes at theparadox.com/073. There's also a link to a YouTube debate he had with a law professor where they debated physician-assisted suicide when it was still up for debate in the state of California. As always, I'd like to thank you for sharing the show, as the show's growth is contributed entirely to you, to the ideas you send me, and also by sharing it with your friends and colleagues and family members. So please, if you can think of someone else who might enjoy the show, send along a link to them, a show that you like. Since I took a week off for Thanksgiving, hopefully you had a nice break. I did. We're back at it, and it's a little bit longer discussion because it's just really fascinating. I just couldn't stop talking to Dr. Kheriaty about this subject. So without further ado, Dr. Kheriaty and the discussion on is physician-assisted suicide good policy? Enjoy. Welcome. I'm delighted. I'm here with my new friend, Dr. Kheriaty. He's an associate professor of psychiatry and the director of medical ethics at UC Irvine Medical School in Southern California. And today we're going to talk about something that I haven't addressed yet in the show. And I actually don't address ethics too often, but when I have the opportunity to speak to someone who is an authority on it, I like to try and snatch him up. So Dr. Kheriaty, thank you so much for joining me on Paradox.
Thanks. It's great to be with you, Eric.
Well, we're going to talk about, I first came across you in one of your pieces that you wrote in New Atlantis this summer on physician-assisted suicide. And then you also sent me a couple other links, and those will be added in the show notes at one's from the Washington Post, The Dangerously Contagious Effect of Assisted Suicide Laws, and then one piece from First Things called The Apostolate of Death. But why don't you go into briefly what prompted you to get involved in, I guess, researching or at least thinking more about physician-assisted suicide?
Sure. So I wear two hats professionally. One is the medical ethics hat, where I do ethics consultations in our hospital at UCI. And of course, many of the cases that we deal with have to do with complex end of life issues, difficult decisions that patients and families or the treatment teams need to make at the end of life. And so from that work, I have a keen interest in end of life care, palliative care, and providing the best care possible for our patients in that very last stage of life. But the other hat that I wear is I'm a psychiatrist. And so about half my time is spent teaching and supervising residents and students and seeing my own patients in psychiatry. And within psychiatry, I have a particular interest in the issue of suicide. I lost a close friend of mine to suicide when I was an intern in medical school. And I think that had a deep influence on me and probably impacted my choice of profession, seeing this friend of mine deal with bipolar disorder and then losing him to suicide. And what I noticed when the debates on assisted suicide started resurfacing, maybe about 8 or 10 years ago, again in the United States, was there was remarkably little attention that was being paid in these debates to what we know about suicide itself, that patients who were requesting help from a physician to deliberately end their life were treated almost as though their state of mind and their motivations were entirely different from other people who wanted to end their life. And based on what I had seen in terms of the patients that I've treated clinically, both as a psychiatrist and as someone who sees a lot of patients at the end of life doing ethics consultations, this didn't make a lot of sense to me. It struck me that while people with a terminal illness certainly have aspects of their situation that are going to be obviously unique to them, in many ways, the things that were motivating these requests were the same things that were motivating patients in the mental health realm that we were hospitalizing for suicidal ideation or after a suicide attempt. So we had one cohort of patients that I was dealing with where we were intervening to try to protect them from suicide and get them through an acute crisis. And then we had another group of patients that people were proposing, not only should we not intervene and try to prevent them from taking their life, but in fact, we should actively assist them. We should ask physicians to actively assist them in taking their own life. And I just couldn't square that up, right? And so I think that was the initial impulse for thinking through these issues, trying to think through these issues, both as a medical ethicist and as a psychiatrist. And then when the debate surfaced in California around 2014, 2015, with the death of a widely publicized case of Brittany Menard, a young woman from Southern California, who moved from California to Oregon in order to avail herself of their assisted suicide law. That sort of sparked the debate again here in California. And then for me, it was, being in the wrong place at the wrong time, Eric. I published an op-ed, and, that led to speaking at the California Medical Association on the issue. And that led to some media stuff, and that led to more writing and more research. And so really my interest in this issue really intensified in around 2014, 2015, when it became a critical issue that was hotly debated in California, the state where I practice.
It is an interesting dichotomy, isn't it? That we have, like you said, on the one hand, we have people who are always advocating for more mental health resources so that people who are in the midst of depression, who have suicidal thoughts, we do everything we can. We suicide hotlines, everything we can to try and help these people. And yet we have, like you said, then we have the exact opposite impulse in certain cases. And it seems, and it is very hard to figure out what we're really trying to accomplish from a public health standpoint. Can you go into? Go ahead.
One of the things that I worry about from a public health standpoint, I'm glad you brought that up, is if we accept that for this cohort of patients, however we're going to define them, it's okay for physicians not only not to intervene to protect them, but to assist them in taking their own lives. I worry that that is going to erode our efforts at suicide prevention in other realms. And one of the reasons for that I've seen as I've debated this issue publicly and really gotten down into the weeds on the arguments on both sides of the issue is that if you look at arguments that are made by proponents of assisted suicide, first of all, there are some powerful arguments that definitely, I think, tap into our compassion for people that are suffering and our desire to eliminate suffering. But if you look at the arguments, they basically boil down to two. The first one is the argument from pain and suffering. So this person with a terminal illness who's going to die anyway is maybe suffering in ways that medicine can't alleviate. If not physically, then existentially or emotionally or mentally, with death anxiety or with all kinds of other anguishing things that can happen to a person with a terminal illness. And if this is the only or the best or the most expedient way to end their suffering, and this is what they want, why shouldn't we give it to them? So that's sort of the first argument that proponents make. And again, it's a powerful argument. I don't find it convincing and compelling, but I have to admit it's powerful. And the second argument that I think is very appealing to us, especially as Americans, with our tradition of sort of rugged individualism, is the argument from personal autonomy, right? So if the person knows what they're asking for, and this is not someone who has late-stage dementia and doesn't know what's going on, they're making the request, it's fully informed, they know what it entails, they know what their other options are. Why shouldn't we respect their autonomy and give them what they want? Okay, so again, another argument that very much appeals to, I think, traditions of thought, especially for Americans and people in modern Western societies where autonomy has become a really preeminent value. But the problem with these arguments, as I see them, is that they do too much work, right? So we make these arguments from pain and suffering and from autonomy and choice, and then we propose laws that try to put narrow restrictions around assisted suicide. I think because that makes us feel better about it, right? So the assisted suicide laws will say things like, well, you've got to have a terminal illness where you only have 6 months left to live, and you've got to have full decision-making capacity. You can't put this in an advance directive ahead of time, and you've got to be over the age of 18, and this, that, and the other thing. But the problem with those restrictions is if you look at the arguments that justified them in the first place, those restrictions really make no sense. They're arbitrary, right? So if the argument is based on pain and suffering, well, someone can come along and say, look, if society allows assisted suicide for someone with 6 months or less to live, why wouldn't they allow it for me? We already see these arguments being made in states where assisted suicide is legalized. So people with ALS, Lou Gehrig's disease, that have a slow, gradual decline, want perhaps to request assisted suicide earlier in the process, so that they can be sure they still have motor control to self-administer the medication. So that 6 month rule begins to look sort of arbitrary, right? Or if we base this on pain and suffering, then someone with a mental health condition that's causing deep anguish can look at this and say, look, on equal protection grounds, I should have the right to do this too, because I'm suffering just as much as this other person. Maybe my suffering is worse. Maybe my physical pain condition is worse. And furthermore, they're going to be gone in a few months, but I'm going to have to endure my suffering for years and years and years, right? So if they should get it, why shouldn't I? And so people talk about this slippery slope, and sometimes I think people mistakenly think, well, slippery slope arguments aren't valid, because basically what they're saying is that this is going to be difficult to implement or difficult to enforce these rules on a kind of practical level. And that's maybe one worry, but I worry about what I like to call the logical slippery slope. And that's basically what I just described, that once the camel's nose gets inside the tent and we say it's we cross that Rubicon. We say it's permissible for physicians to help patients take their lives. Then I think on the basis of the arguments that we've already accepted to justify that, we're going to see a logical progression to expanding the criteria of people that would qualify. And if you look at countries that have been doing this longer than we have, if you look at Belgium, if you look at the Netherlands, you see that's exactly how things play out when this social experiment continues as it has in those places.
So specifically about Belgium and the Netherlands, I feel like I read recently, a year or so, that they started euthanasia for children, or at least
that's right.
Do you think that's a natural extension of the physician-assisted suicide? That at some point suicide or planned death, I guess you'd call it, is more acceptable. That it just becomes more acceptable to have other things that are okay.
I do, because try to think of another situation in medicine in which we had a novel intervention. I'm not going to call assisted suicide a treatment, because I don't think it's a treatment.
No,
treatments heal people, and assisted suicide doesn't do that. But a novel intervention that we offered to adults that did what it was supposed to do for adults, that we would not offer to children in the same circumstances,
right? Yeah.
Knowing that it would have the same effect on children. I can't think of another example of that. So again, the restricting this to adults seems sort of arbitrary. If we believe that this is a good or a benefit that we would offer to people at the end of life, why would we keep a good or a benefit or an intervention that did what we intended to do? Why would we keep that from children that are suffering in the same way? It doesn't seem to make sense. So I think that is a kind of logical progression. I think it's not good that happened, but if you accept those premises, it's hard to resist the momentum of where they're going to take you. Also in Belgium and the Netherlands, we've seen the extension to people with mental illness, but who do not have a terminal illness, people with refractory depression or personality disorders that have proven very difficult to treat. There's been a number of very well documented, well publicized cases in that realm. And in fact, people in older age brackets in those countries can now make the request just based on the fact that they're tired of living, or the fact that their spouse with a terminal illness is going to be doing this, and they want to die together. They don't want to outlive their spouse. Again, there's been a few cases in some of these countries of married couples doing paired assisted suicide, where one of them was terminally ill, but the other one was not. And again, I think what we see in that social experiment that's been conducted in those countries is this is where things will logically take you once you accept the basic premise that this is permissible.
Yeah, I think to further point out the point you made about children, there are all kinds of off-label uses we use for medications that we use for children that have never been tested on kids, but we see that they ease suffering or treat pain, like using morphine, for instance, for kids. It's never been tested in children, and you'd be a monster not to use them for kids. And so, as you said, if you have a treatment that works, why would it not naturally extend to others? I've always found it interesting, the end of life, just the comment that something's end of life, and the same argument is used for the use of healthcare resources. For instance, the end of life care is half the amount of healthcare you spend in your life you spend in the last 6 months of your life. Of course, the problem always is you never really know what the last 6 months of your life is. I mean, and how many people have you met in your life who have told you, "Oh, I was told I had 6 months to live," or "I was told that this is a terminal disease. I had, whatever," and they far outlive, and sometimes they beat whatever it was. And so, our scientific knowledge of how long someone is going to live is very limited. It's not nearly as precise or accurate as we think it is.
we're very good at prognosticating death when it gets to the point where it's hours to days away. We're pretty good when it's weeks away. When we get to the 6-month realm, which is what the laws are premised on in the United States, at least, our prognostication of death is very, very hazy. And there's actually an interesting, if you look at some of the data from Oregon that has been doing this since 1997, longer than any other state, roughly half of the people that get a prescription for the assisted suicide pills don't take them. They either change their mind and choose not to take them after all, or maybe they die of natural causes before they take them. And it's hard to follow all of those folks, but there have been a few studies that have followed some of the folks that have gotten the prescription and not taken them. And it's clear that a fairly substantial proportion of them live another year or two. Mm-hmm. And so again, these were people that under the law were deemed to have 6 months or less to live, and clearly outlived that prognosis. And thank goodness they chose not to take the deadly drug when they still had a couple of years of life ahead of them.
Sure. Well, I mean, you see this at hospice all the time, right? People,
sure.
You can't go to hospice unless you have a terminal disease. And of course they're, still there after 9 months or a year, perhaps, because maybe that's the care they really needed. Sometimes not as who knows? Because our ability to predict is so poor. I actually have a friend who's a physician, and the first thing he tells a patient is that he said, you will die. I will not prevent you from dying. So, so he's pointing out that, we can't prevent you from death, because life is a terminal disease in many ways, right? We can never predict that.
The human mortality rate continues to hold steady at 100%.
Right. Yes.
Despite all the miracles of modern medicine. And so, that's a really important point, Eric, when we're talking about assisted suicide, that my opposition to assisted suicide does not mean that I subscribe to a kind of vitalism or continuing to sustain or maintain life medically at all costs. I think actually those two things might assisted suicide and extending life medically at all costs might be sort of paradoxically two sides of the same coin, because both of them involve a kind of denial of death, right? A kind of notion that we can completely control the timing and circumstances of our own death, that lacks the kind of humble acceptance that, death is the one event in our life that I think most fully and most finally reminds us of our lack of complete mastery and control. We all want to be the author of the story of our life, but still there are going to be things that happen to us that we didn't choose autonomously. And I think death is the sort of paradigmatic example of that. And we end up giving bad medical care when we go off the rails in one of those two directions, either intentionally as physicians trying to foreshorten life, or kind of brutalizing people at the end of life by continuing medically futile interventions when they're no longer beneficial and when they're just prolonging the dying process unnecessarily. And I think it's important for patients to know that medicine is committed to not killing patients deliberately, but is also committed to making sure that patients are comfortable in their last days, and not behaving as though death is the last enemy for medicine to conquer, which is just sort of futile and ultimately a sort of folly and hubris on our part.
Yeah, I think it's important to recognize as physicians that our goal is to cure disease, and when we cannot cure it, we ease suffering, but I don't think we rarely have the capacity to end suffering. I think that's not really in our bag as far as.
That's right. We try to mitigate it to the degree that we can, but the proposal to eliminate suffering by eliminating the one who suffers is quite bizarre when you At least it's bizarre to me when you
Yeah.
think about it. Many people find that notion, I think, plausible or convincing, but it seems quite nonsensical to me.
Well, I'd like to shift to focus a little bit, because one of the things I found very interesting, and I was sort of aware because I've read, I think, one of Malcolm Gladwell's books where maybe it's Tipping Point, where he talks about suicide on some island somewhere, and it became sort of, for lack of a better word, trendy, right?
Yeah.
Why don't you talk about the social phenomena of suicide, and I guess to start there, and then maybe talk about how that's been affected by various, the state laws and countries that have adopted a different, viewpoint towards suicide.
Sure. So this is one of the concerns that I expressed regarding assisted suicide, and that has to do with what we know about the social contagion effects of suicide. And this research goes back 100 years to the seminal work of Emil Durkheim, who's probably not familiar to a lot of clinicians, but he's sort of the founding father of modern sociology. And he wrote a book on suicide that looked at suicide rates around the world and noted this social contagion element. And actually even further back than that, historically, anecdotally, the phenomenon of social contagion with a well-publicized case of assisted suicide is called the Werther effect. And that comes from an 18th century novel by Goethe called The Sorrows of Young Werther. And the protagonist in the novel is thwarted in his romantic pursuits, and he ends up taking his life with a pistol. And this was a wildly popular novel in Germany and Italy when it was first published. And the authorities there noticed a rash of suicides, especially among young men, using the same means, shooting themselves, many of whom died with the book tucked under their arm, right? And so again, that was anecdotal a few hundred years ago, but social science has replicated that phenomenon many times over, to the point where now it's sufficiently well established that the World Health Organization and the CDC have both published guidelines for journalists and for media on how to report suicide so as to try to minimize the Werther effect. So that's one of the ways that suicide contagion spreads, is through well-publicized cases, especially if they're presented in the media as romanticized or as a potential solution to difficult problems.
Mm-hmm.
But the other thing that happens, even when the case is not publicized in the media, is that suicide tends to spread person to person through social networks, through kinship networks, through friendship networks. The person who's done the most work on this is Nicholas Christakis at Yale, who's shown that many health-related behaviors, both positive and negative, anything from weight loss and smoking cessation to drug use, and including suicide, can spread through social networks up to 3 degrees of separation. And so if I were to take my life tomorrow, then not only my friends, but my friends' friends' friends would have an elevated risk of taking their lives over the next year. That's statistically significant. Now, the risk drops off, the effect drops off with each of those 3 degrees of separation.
Okay.
So it has more impact on the people closer to me than on the people further away in that social network. But it's still statistically significant up to 3 degrees of separation. So what does this mean for assisted suicide? Well, we saw overall suicide rates in Oregon rise dramatically in the decade following the legalization of assisted suicide in that state in 1997. There's data now published by David Albert Jones, a colleague of mine in the UK, who looked at assisted suicide in 3 states after it was legalized in the US, and tried to control for various confounding factors and time-dependent factors. And his study strongly suggested that the rise in overall suicide rates in those states, assisted and unassisted suicide rates in those states was impacted by the laws permitting assisted suicide. So I think we have a lot of reason to believe now that when we talk about assisted suicide, we're not just talking about an issue of individual autonomy. That's, this is my decision. It's my body. It's my healthcare. If I decide to do this, it's not going to have an impact on anyone else. Well, I think we have some good reason to believe that that's not the case, right? That maybe proponents of the laws would like to think if we legalize assisted suicide for this very narrow population, let's say terminally ill individuals, that we don't have to worry about the effect that it's going to have on the depressed 13-year-old young woman who, just got dumped by her boyfriend and is hospitalized with suicidal ideation and is struggling with an eating disorder or whatever. But in fact, that young woman may take a look around and say, well, I know my grandmother did this a year or two ago when she got really sick and when she was suffering. And, everyone around her seemed to think it was a good idea. In fact, they had a little going away party for her before she took the pills. If it's okay for her, why wouldn't it be okay for me? So I think, Eric, another reason to worry is that laws themselves have a kind of pedagogical function, right? They not only tell us what's going to happen if we do A, B, and C, but they also shape our perceptions of what is socially and morally acceptable, right? And so if a law says that this is socially and morally acceptable, I worry that that's a message that's going to be heard not just by people in some narrow category, like people that have a terminal illness, but that's a message that is going to resonate with other people who are vulnerable and at risk for suicide as well.
And you'd argue that that's been borne out by actual results, right, from the various states.
I think it has. And admittedly, the data there is preliminary. We've got a couple of studies. We've got a couple of studies on the Werther effect specifically for assisted suicide. We need more data, and I think we should continue to monitor those suicide rates and do some comparison studies in the states that have legalized it. But also recognizing that this has become a part of the national conversation as well. So the effect may actually extend beyond the state in which it's legalized. So yeah, there's always a need for more research on these complex questions of public health, and there's room for debate. But my read of the literature is, I think we have plenty of theoretical reason to believe that this could happen, and I think now we have some empirical reason to believe that it in fact has already started to happen.
Well, and I certainly think when you look at other social phenomena, like you mentioned drug use, or say smoking is a great example. I mean, and that's an interesting one in the sense that smoking is legal. I mean, I guess you could argue there are smoking bans in public spaces in some states. I'm not sure how many. I know Michigan has one, but the rates of smoking in even the young have been declining for years now because of a public campaign and social stigma, I guess, towards smoking. And so it's funny because I do think with suicide, there are very few people who you'll meet who are in favor of suicide. I mean, they're concerned about people in their family becoming suicidal. It's only like you mentioned in this extremely narrow portion, or it's almost a theoretical, if it's not, not even someone I know who's okay with it. But if someone thinks it's okay for someone with a terminal disease or whatever it might be, then it would seem like a reasonable solution to someone who may be battling with, like you said, depression, or because I think it feels like people with depression and people who use suicide are people who have had a narrowing of their mind, I guess, and sort of options for them. Right. And it's not so much. And so they just need to sort of realize the other ways out of whatever the problem is that they're facing. That's right.
So typically the suicidal mind, very often this is going to be associated with depression. One of the effects of the depression is to narrow and constrict my scope of thinking so that it becomes harder to get a kind of breadth of vision that allows me to see alternative solutions to problems, or to see hope for the future. People can endure a lot if they believe that, it's possible that things could get better, or maybe there's a better treatment for my physical pain condition. And so what happens is it's not that people want to die or they want to embrace death necessarily. It's that their thinking has become constricted and rigid. They're suffering in ways that they perceive are intolerable, or they're afraid that might happen in the future if they don't take action. And so they see suicide as a kind of escape hatch.
Yeah.
But the suicidal mind tends to be very ambivalent. The number one suicide spot in the world is the Golden Gate Bridge. About 2,000 people have died from the bridge that we know of since it was first built. Only a couple of dozen people have survived. It's almost impossible to survive that jump. But journalists tracked down the individuals that had survived that jump from the Golden Gate Bridge. He asked them a very interesting question. He said, what was going through your mind in the 4 seconds between when you jumped and when you hit the water? And every single one of them said the same thing. They said that they regretted having jumped. One guy said, I realized in an instant that all the problems in my life that I thought were unsolvable were actually solvable, except for having just jumped. So, we see this with suicidal individuals. If you get them through a crisis and you follow them out 10 years down the road, most of them either die of natural causes or are still alive. The vast majority of them, 80 to 90% in most studies, have not gone on to take their lives later. And also, if you ask them, are you happy that people intervened, even if it meant something like involuntary hospitalization, something that you didn't want at the time? A majority of them will say, yes, I'm glad that people intervened, even though I didn't want it at the time, to get me through that crisis, right? Because I've found meaning or purpose or hope, found relief from my depression or whatever it was that they were suffering from. And so, another worry of mine with this whole issue is the impact it's going to have on end-of-life care. Because, I think the right way to deal with a request for assisted suicide is to begin with the assumption that this is a canary in the coal mine, that this is a distress signal that the patient is sending out that suggests that, something on the physical or psychological or social or spiritual level is not being attended to adequately. I'm in pain, or I'm depressed and feeling hopeless, or I'm afraid. I'm afraid of becoming a burden on other people. Very common reason people give for requesting assisted suicide. And I think the compassionate response to that is to inquire and to do comprehensive assessment, and then to offer the patient what we have available to treat their undertreated or untreated pain, or their untreated or undertreated depression, or to communicate to them that it's not a burden to care for you. It's a privilege, and we'll continue to care for you right up to the end. And this is what will be available to treat your pain or your air hunger. I talked to a person just last week, a patient of mine with a terminal illness who's worried that she's going to suffocate to death with her lung cancer, and that it's going to be distressing and painful. And I needed to educate her on the palliative care option and what we can do to make sure that a person with lung cancer doesn't die in having respiratory distress. This is bread and butter, very basic palliative care, but it's not something that lots of folks necessarily know about. And I think what happens with assisted suicide is it becomes a cheaper and more expedient and more convenient solution to very complex, difficult and expensive end-of-life situations. And I worry that some of those folks that could have been treated with better end-of-life care maybe get shuttled too quickly down the assisted suicide pathway. We know a lot of these requests are associated with depression, but if you look at the data in Oregon, only 3% now of individuals in Oregon who have received the prescription for the deadly drug for assisted suicide, only 3% of them were ever referred for psychiatric or psychological evaluation before they got the assisted suicide pills. So that number worries me a lot, because I think there's a lot more folks in that cohort who probably needed a comprehensive psychiatric evaluation for depression or anxiety or loneliness, and probably didn't get it. Those issues may have been overlooked, where they should have been more adequately addressed.
Yeah, I mean, there's no question. I think you'd be very concerned that if people, I mean, there aren't many people who ask for suicide, and there's obviously those psychiatric components to it. It concerns me, the thought that, well, I'm in Michigan, and certainly I remember when I was a kid, Dr. Jack Kevorkian was very much in the news.
Yep.
And
right.
Dr. Death, if people may recall, he had had a traveling van. I guess he'd go to people's houses and he'd administer their IV cocktail and kill people, or assist suicide, I guess, however you want to phrase it. But there are definitely going to be people who are specialists in this sort of thing, and their business model is not one of healing and fixing people.
That's right.
They may have a questionnaire or something. I imagine they'll have some sort of thing they'll have in place to say that they adequately assess people and said that it's this is an appropriate treatment. But I mean, that would be a huge concern of people going around killing people, and that's their business model.
Yeah, and it sounds maybe alarmist and kind of macabre, but these folks are out there, and they've been enthusiastic about assisted suicide for a long time, and in the states where it's permitted, they're now sort of surfacing with clinics that are specializing in this. And I mentioned one of them. This is a fellow I debated a while back on, I think it was on NPR on the radio. But in the New Atlantis piece, First Take No Stand, I talk about a doctor up in the Bay Area who opened a clinic specifically for this purpose. You can go in and pay your couple $1,000, get your 2 visits with a doctor that you haven't met before. You haven't been under his care. He's not board certified or trained in palliative care or oncology, or I think he's an emergency physician. So not necessarily someone that has a lot of clinical training or experience dealing with chronic conditions that are terminal or life-threatening. And that model of practicing medicine worries me a lot. It worries me not only for the patients that are going to be going to these clinics and getting what is often going to be substandard care, but also just in terms of the public's trust in the profession of medicine. With folks like this operating out there, I think there's a danger of people becoming excessively wary of even appropriate end of life care. One of the things that I do on the ethics committee often is have conversations with families that are making making a decision for an incapacitated loved one.
Sure.
And it's obviously it's going to be anguishing if that decision is to maybe transition to comfort care only and allow natural death. And it became more difficult to have these conversations after assisted suicide was legalized in California. Not because we do this in our hospital. We don't do it in the inpatient hospital at UCI, but just knowing that it was out there in California made a lot of families very suspicious and nervous about having end of life care conversations, because they were worried that when we suggested something that was entirely medically and ethically appropriate, like continued treatment down this pathway is not going to be curative, let's think about moving toward comfort care. They worried, and I think understandably, that what we were suggesting was the equivalent of euthanasia or or assisted suicide. So this whole proposal to permit this has really muddied the waters, and I think made it harder to maintain that important ethical distinction that's been upheld by the U.S. Supreme Court between doctors killing, which is impermissible, and doctors allowing natural death when medicine has reached its limits, which of course is permissible.
Yeah,
that's a central distinction to traditional Hippocratic medical ethics, and it's in danger of being abandoned. And that's not good, not just for people who may avail themselves of assisted suicide and euthanasia. I think that's not good for end of life care in general, because it just confuses and clouds the picture for everyone and makes people unduly suspicious of options that may be medically appropriate.
Yeah, I'm always bothered by the fact that physicians get roped into things that really are out of our purview. And one is medical marijuana, for instance. I mean,
right.
Whether you use marijuana or not, I don't know why a physician has to be involved in this decision. I mean, like why it's not, we're not prescribing dosing or anything like that. It's like, yeah, go ahead and smoke it or not smoke it. It's sort of like the extent of it. And then it's, why are we in this? And I find the physician-assisted suicide so strange that why are physicians even involved in this? I mean, why don't you have, long-haul trucker-assisted suicide or, electrician-assisted suicide? Why do you have to have physicians? Because as you and I know, there are millions of ways to die. There are millions of ways to take your own life if you wanted. You can pass all laws you want outlawing it, but there's nothing you can do to someone who successfully, kills himself. And so, so the state is very impotent in sort of what it can do. And as a libertarian, you would say, well, people have their own choice, and I would say they always have their own choice, and only in the most extreme circumstances would someone not be able to, commit suicide and remove themselves. I mean, you'd hope that they don't, but
exactly,
So why are we involved?
Right. So suicide is not illegal. What's illegal is helping someone else to take their own life, right? On the quite reasonable assumption of and premise of social solidarity with someone who's suffering. So I'm not under any illusion that we can prevent any and all suicides, but certainly we can avoid, especially as physicians, directly aiming at or intending the death of our patient by our interventions. But I think to answer your question, why proponents or advocates are so interested in getting physicians involved, I think the reason is that it lends a certain veneer of respectability and prestige. It kind of sanitizes an inherently ugly reality and makes it more palatable. It makes the poison go down easier, if you'll excuse the pun. Right. Because if you say, doctors should be allowed to kill their patients, or people should be allowed to help other people kill themselves, most people recoil in horror from that blunt, clear, and quite accurate characterization of what we're talking about here, right? But if you can cloak it, if you can first of all give it the sort of white coat mantle of prestige and respectability, right? People generally have regard for physicians, right? In spite of everything, and still these days, maybe not as much respect as we once enjoyed, but in general, it's seen as a helping, other regarding, generally kind of noble profession. And if physicians are doing it, it seems to lend some kind of moral credibility to it. And then if we can alter the language in which we describe it, we can avoid the word suicide, because people don't like that for obvious reasons. If we can talk in sort of fuzzy euphemisms like medical aid in dying, that again don't really clarify what we're talking about, because of course palliative care physicians give people aid in dying all the time. That doesn't mean that they kill them. It means they accompany them and provide care in their last days. So so I think it's important for us when we're talking about this issue to be very clear about what's going on, to be very clear about the language that we're using. And I was edified by the decision of the World Medical Association. This happened since I published the piece, which goes into a lot of kind of discussion about what medical associations are doing in regards to assisted suicide. And the World Medical Association, their decision was still pending at the time of publication, but they recently came out with a very strong statement maintaining their opposition to assisted suicide. And they also refused to change the language that they used to describe the act, saying that assisted suicide is the most accurate language to describe what we're talking about here. So proponents want not only to change laws, they want to change the way in which we talk about this. They want to change the language, because if you change people's language, you can slip certain things by them and sort of soothe them to sleep, rather than kind of jolting them awake with the cold shower of, exactly what we're doing here.
Sure. Yeah. It's very similar to, I think it was the Obama administration that said, "Oh, we're not at war. It's just a kinetic action. We're
right.
Right.
Yeah, exactly.
Right. In another country. Right. And so it's not, and by changing the language, you absolutely change the tenor of the debate, and you put people, most people, they don't know what you're talking about. And that's that's the whole point, right? To just make it confusing. If you could just briefly talk about the one thing you mentioned in your piece. So, I mean, we've been talking a lot about physician-assisted suicide and suicide in society. And I think the suicide rates are going up in this country.
They are. Yeah, we're seeing an epidemic of suicide since 1999 among both men and women in basically every age category, except for those over the age of 75. We've seen a slight drop for the most elderly cohort, but everyone else, we're seeing a very alarming rise in suicide rates that's affecting especially women and especially young people. So suicide rates for 10 to 14-year-old girls have tripled in the last 15 years. Ugh. And suicide is now the second leading cause of death among adolescents and young adults, people in their teens and in their 20s, which is just astonishing. It surpassed motor vehicle accidents in that age group, which is so awful.
Yeah.
This is a serious issue that we're facing as a society in general, outside of the issue of physician-assisted suicide.
Right. Well, my wife is a pediatrician, and she started her own show a few months ago called Losing a Child, Always Andy's Mom, where my wife and I lost our 14-year-old son in a car accident last summer.
Oh, sorry to hear that. That's
thank you.
Devastating.
It's been awful. And I can tell you from a depression standpoint, I definitely felt like I had never had the symptoms of, I remember seeing patients who had anhedonia and these sort of, these symptoms, and I experienced them, right? I had all these things. I'm like, wow, sure. I never was suicidal. But I could see why when you're in depths of sorrow, that you definitely see the narrowing of sort of just existence. And it's really tough to even see the tomorrow, much less, a year from now.
Yeah.
And
exactly.
I'm much happier that, I'm now further down the road and as my wife. And so she started the show to help other parents who are with their kids grieving. But one of the guests she had on the show had a daughter who committed suicide, and in her class in a very small town, there were 3 kids who committed suicide. And to speaking to your point, where it's sort of, you affect the people around you, they start seeing it as an option. Yeah. How do you reverse it? I mean, because as it becomes a phenomenon, there must be a way to add a stigma to it, right? Just like there was with smoking.
Yeah.
I mean, how do we reverse that and fix that problem?
So I think it's going to take collective efforts on a lot of different levels. We have to bind up the individual wounded, and there has to be the crisis intervention and the follow-up for probably at least a year after the suicide of someone in his school with other individuals who may be at elevated risk. So the first people first thing that people tend to reach for when there's another tragic suicide, especially of a young person, is more mental health resources.
Right.
And I'm all for. I'm a psychiatrist. I'm all for.
You
that.
are a mental health resource.
I'm a mental health resource, and so primary care physicians need more training in because they're on the front lines, and there are not enough psychiatrists to deal with all the mental health issues that we're facing now as a society. So yes to that on the individual level, but I think we also have to look as a society at, as you said, at the ways in which we're portraying suicide. I was very concerned about this show, 13 Reasons Why. I wrote a review of it called Killer Show, which is also at First Things. And basically what I did in that piece is I went through those World Health Organization CDC criteria that I mentioned earlier about how not to portray suicide in the media, and basically showed how that television show 13 Reasons Why, which was produced by Netflix, systematically violated those norms across the board. I just went through each one and gave examples from the show of why it perhaps with good intentions wanted to deal with the issue of teen suicide, but the way it went about it was completely, I thought, counterproductive. So, and a lot of psychiatrists came out with very, very strong critiques of 13 Reasons Why. And there were several studies, including some methodologically pretty rigorous studies. One of them appeared in JAMA, basically showing that suicide rates spiked after the show aired, and there were more suicides among teenagers. There were more visits to EDs with suicidal ideation. So this show, which was, I think, at least at the time, it was the most popular show on Netflix. Teens were binge watching this, often just alone or with their peers without adult supervision and guidance. And
as
someone
teens
who's probably, exactly, as they want to do. So someone who's not contemplating suicide would probably watch this show and see it as a kind of cautionary tale and a tragedy. But someone who is struggling or suffering could watch the show and take an entirely different message away from it. And when the CEO of Netflix was challenged on the effect that the show was having, his answer was distressingly callous. He basically said, if people don't want to watch it, they don't have to watch it.
Right.
And it's making it's making a lot to money. Like in the same quote. Yeah. I mean, it was awful. And so, I think we need to hold the gatekeepers of information and of influence responsible for this sort of thing, and especially with something like this, obviously, where there's a lot of money and other interests at stake, demanding a kind of accountability and responsibility. You just can't put things out there and then wash your hands clean of the social consequences of what you're doing. So I think social responsibility, and we have to deal with the problem of loneliness. That's probably a topic for a totally different podcast, different show for another day. But hand in hand with the rise in suicide and the rise of what researchers now call deaths of despair, which is suicide, drug overdose, and alcohol-related deaths. We're seeing a rise in loneliness. People are more and more socially isolated today in the U.S. and many other Western countries than they were 40 or 50 years ago. The retired Surgeon General under Obama declared loneliness to be a public health crisis, and made the argument that the effects of loneliness on physical and mental health were comparable to the effects of smoking on heart disease and this sort of thing. So this is very real, and we've got a lot of robust data now on the physical and emotional effects of social isolation and loneliness, and obviously that's not a problem that's going to be solved by a pill or a prescription pad, or even by more mental health resources. That's a problem that all of us are going to have to take some collective responsibility for addressing.
Yeah, and I think when you hear the plea that there's these problems for mental health, that the solution is always more resources, it probably isn't. It probably is in many ways. It is a society thing. It is talking to your neighbor. It is building communities within stronger.
That's exactly right.
Community structures with you through your church, through your school, through your work, whatever it might be. Right. I mean, because as much as it's easier now than ever to socially interact with people, to meet people with similar interests, and to with social media, as much as it's been denigrated. I think in some ways it's fantastic, and sort of the ability to form new relationships with people, I think it's easy to sort of cast aspersions at it when it's probably not warranted. It's not fair. But like you said,
it's a mixed bag, and it's how you interact with it. I mean, social media brings people that are at great distances very close together. Right? I mean, someone who's halfway around the world, someone who's on the other end of the country, we can stay in touch so much more easily and consistently than we ever could before. But there's this kind of paradoxical effect that, people that are, down the hall from me or next door to me, it may actually push me away from them.
Right. They might as well be on the other side of the world.
Screen. They might. Exactly. So it's how we use it. It's how we interact with it. It's the effect that it has in the home and on the family if people are not kind of vigilant about the place that it has in their lives. And I think that's especially hard for young people that don't have some help and some guidance in this area. If we just give them the smartphone and let them have at it, they can be up till 2-3 in the morning on social media every night, interacting in ways that are not always helpful for them.
Yeah, well, that's what young people do. They do things that they lack wisdom, and that's what we supposed to provide them as best we can. Well, I really appreciate the discussion. It's fascinating. I'm looking at our interactions in the Michigan State Medical Society. This is something that I know people are talking about. I don't think that's any movement to legalize or try and move that in the state of Michigan. But I think, these things, certainly I feel like it started in Michigan. It didn't end up happening with Kevorkian, but that certainly he started the discussion at a nationwide stat. How do people find out more? You're writing, is there a place where you sort of warehouse it all on your website maybe? Or
so there's AaronKheriaty.com is my website. It's spelled Kher. So you can find some stuff there. I haven't posted all my stuff there. I'm a little backlogged on things, but there are a few resources there, including I think links to most of the articles that I mentioned on the show. I don't think I have the New Atlantis piece up there yet. But they can go to AaronKheriaty.com if they're interested in more on this issue or more on other things that I've written about or spoken about.
Are you on Twitter or LinkedIn?
I am on Twitter as well, at Kheriaty. So,
okay. Well, those and all the other links to the articles we talked about today, and a couple other ethical shows I've had too, which relate to the brain death and organ harvesting, will be available on the show notes. Well, Dr. Kheriaty, thank you so much. I appreciate it. And I hope we have a chance to talk again about something else.
Likewise. I would enjoy that. Thanks. This has been fun.
Oh, great. Thank you so much.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.